consultant at Bharti Hospital, Karnal. Over to you, sir.
Hello, Ankur, and Happy New Year to you. Happy New Year to everybody
Yeah.
who is logged in with us today. It's great being able to connect on the first day of the year. And thank you, Dr. Helen Jayadevi, for joining us. This is an English session. This session is planned for doctors, actually. And the sessions that we have on KK Med Talks from 7 to 8 p.m., they are a mix of Hindi and English. So this is a session for medical professionals, and we will be speaking in English only. And thanks, Dr. Helen, for joining us and reminding us. Once again, best wishes to all of you for a happy and a healthy new year. Also, best wishes for a peaceful and prosperous new year. There seems to be a shortage of peace in the world. There also seems to be a shortage of health in the world, and newer diseases are coming up. So, one of the diseases that is becoming more and more rampant in the world is diabetes, of course. But diabetes doesn't come in isolation. Diabetes comes with a myriad of complications, a myriad of comorbid conditions. And that is why sometimes we use the word syndrome for diabetes. The word syndrome means a constellation of or a group of symptoms, signs, and laboratory abnormalities. This is the classic definition. Another definition that you may use is a constellation of complaints and concerns. So, a common cold, for example, is a syndrome. It can have a little bit of runny nose, sneezing, cough, fever, body ache, malaise, a little bit of all of the above, maybe a few of the above. That's why it's a syndrome. Similarly, diabetes is a syndrome because there is a wide group of complaints and concerns associated with this. Some patients may present with some of them, others may present with others. Today, we'll speak about polycystic ovary syndrome. Note the right word, it is polycystic ovary, not ovarian, and syndrome, not disease. The reason is that it is a syndrome. It is a constellation of symptoms, signs, and lab abnormalities, or a constellation of complaints and concerns. It is also ovary because the ovary is polycystic in appearance, but that doesn't mean that the etiology is ovarian. It is not an ovarian syndrome. It is a multidimensional, multifactorial, a multifaceted syndrome. So the right term is PCOS, polycystic ovary syndrome. PCOS is actually the commonest endocrine disorders in women of reproductive age. It's even more common than diabetes and more common than hypothyroidism. It presents with hyperandrogenism, that means high levels of testosterone, and disturbance in ovulation, which means the egg formation or the ovulation formation may be disturbed. It can occur at any age from adolescence to womanhood, that is the reproductive age group, from menarche up till menopause. And the effects or the residual effects may continue even after menopause. But in general, you will define it as hyperandrogenism, hypoovulation from menarche to menopause, which causes physical and psychological or psychological comorbidities and complications. So complaints and concerns. And now suddenly, when we think of it, all the girls, all the women coming to our clinic, all of them have got concerns and complaints. They have comorbidities and complications. That's why they're in the OPD. But if these are occurring because of an endocrine disorder, if they are associated with hyperandrogenism or hypoovulation, only then will we think of PCOS. Now, why does PCOS occur? We just said that it is not an ovarian pathology. Actually, to be honest, we don't even know the pathology right till date. But the basic premise seems to be insulin resistance. So you can have this debate going on and on, which comes first, the chicken or the egg? And whether that debate can be answered or not is a separate matter. But here in PCOS, the answer is that first of all, it's insulin resistance. There is insulin resistance at the systemic level throughout the body. And then there is insulin resistance in the ovary. So these are two aspects. Because of the insulin resistance, you have high levels of insulin. The body has to work more insulin has to be secreted. When there is more insulin secretion, that leads to downstream metabolic and mitogenic effects. Metabolic and mitogenic effects. Metabolic effects will present as hyperglycemia, dyslipidemia, and mitogenic effects will present because of increase in something called IGF-1. So not only do you have increase in insulin, you will also have increase in insulin-like growth factor 1. Uh, Increased insulin and increased IGF-1 will have mitogenic effects, which also include increase in androgens, free androgens. And these can lead to complications like hirsutism or acne, and also to menstrual irregularity and infertility. So, one aspect is insulin resistance and the mitogenic downstream effects, leading, of course, to hyperandrogenism. But apart from that, the insulin resistance may also trigger a hormonal imbalance at the level of the hypothalamus. So, what happens in the hypothalamus? There is something called GnRH, gonadotropin releasing hormone, which is released in a very pulsatile manner. This pulsatile secretion of GnRH is disturbed in PCOS. Because of that, there is abnormal release of GN, gonadotropin, from the pituitary. More LH is released, less FSH is secreted, and this hormonal imbalance also impacts the ovary and can cause infertility. It can cause anovulation or hypovulation. So let us repeat what we have done so far. Insulin resistance leading to mitogenic as well as metabolic downstream effects. Also, there is increased GnRH pulsatility, and that impacts the ovarian function. And apart from that, there is the aspect of the liver as well. There is decrease in sex hormone binding globulin. Because there is reduction in sex hormone binding globulin, less binding is done to the androgens, to the testosterone that is present in women, and therefore there is more free testosterone. And that free testosterone impacts ovarian function and also dermatologic health. But now let's come back to diabetes. Our topic for today is diabetes essentials. So women with PCOS, whether they are obese or lean, they will have insulin resistance, and that insulin resistance may present as frank type 2 diabetes, as impaired glucose tolerance, that is pre-diabetes, and some people may be non-diabetic or euglycemic as well. But meta-analysis suggests that the type 2 diabetes risk in PCOS is not directly because of PCOS. It is specifically due to increased body weight or due to hyperandrogenemia. So even lean women with PCOS who have got high levels of testosterone, they are also at risk of type 2 diabetes. This is not surprising because even when you look at men, hypogonadal men, men with hypogonadism are at greater risk of type 2 diabetes. Men with type 2 diabetes are at greater risk of hypogonadism. And in women, it is opposite. Women with hypergonadism, that is hyperandrogenemia, are at greater risk of diabetes. So there is a gender dichotomy here. PCOS, like we said, is multifactorial, multifaceted, and one of the factors is genetics, and this is something that is being studied. Now, why did we choose this topic for today? Last week we had spoken about testosterone in men. Today we are taking testosterone in women because it has a lot of implications on health. Not only cosmetic health or makeup health, but also metabolic, mental, and maternity related. So remember the M's. M for makeup or cosmetic, just to remember. M for metabolic, diabetes, hypertension, obesity, dyslipidemia, fatty liver. M for mental stress, psychosocial issues. And M for maternity and menstruation, so difficulty in fertility, subfertility. Because of all these M's, it is good to follow a biopsychosocial model of health. And actually, to be honest, this is something that has helped me a lot in my practice. Whatever you are looking at, whether it is diabetes or polycystic ovary syndrome, even COVID-19 prevention and treatment, think biopsychosocial. Recently, we had a patient in our hospital and there was an absolute indication for cesarean. But the lady just refused to agree. Finally, she did agree at the end, but by that time, unnecessary trauma, unnecessary arguments had gone on. And the reason was that we had not taken a biopsychosocial history. The history basically was why she was trying to avoid a cesarean was she had no backup at home, no one to help her. And she thought that if I undergo a cesarean, I will not be able to work, I will not be able to go to the kitchen for 40 days. Someone had told her that. And so she wanted to avoid that 40 days rest because there was no one to help her out at home. And with normal delivery, she was told you can get up and go to the kitchen the next day. So this was a psychological thought process, a social issue. Had we taken the history earlier, had we counseled her that even after a cesarean, you can get up and you can take care of your baby after two days or so, then she might not have got so upset. She would not have argued with us. So this biopsychosocial model is something that we must integrate in everything, whether you are managing metabolic disease, even when you are managing acute disease. And we learned in our hospital, even when it is a discussion about cesarean section versus vaginal delivery, even then psychosocial aspect must be probed. So similarly, in all women who come to you in the diabetes clinic, please do probe for polycystic ovary syndrome and see what impact this is having. Is it impacting their mental health, maybe causing depression or anxiety? Is it impacting their sexual health, their thought process? Maybe their eating behaviors. Do they have anorexia nervosa, bulimia nervosa? These are not very common, but something that you will commonly encounter is orthorexia nervosa. So, what is orthorexia nervosa? Ortho means upright, standing up straight. Orthorexia nervosa means an unnecessary and extreme obsession with eating right. So each and every time you are counting calories, counting carbohydrates, counting fats and fibers, and you stop enjoying the taste of food because always you are reading the food labels. That is orthorexia nervosa. Until you take the history, we won't find out. Also look for social things, self-image, self-esteem. Is the girl being bullied at school? Does she feel afraid that she won't get married? She won't find a loving partner? Is she getting support from the family or society? All these are things we must ask about to every girl, every woman who's coming to us in the clinic. But then you will say, we've done so much of theory. What about practical? How do I diagnose polycystic ovary syndrome? So there are different diagnostic criteria. And usually what we follow is the uh, NIH 2012 criteria. So now here, 2 out of 3 dysfunctions must be present. The first is hyperandrogenism, which can be clinical or biochemical. So clinically, acne, hirsutism, male pattern alopecia. Acne, hirsutism, male pattern alopecia. Biochemically, a high serum testosterone. Either or both of these will suffice to diagnose hyperandrogenism. But the hirsutism should be the testosterone dependent terminal hair. That means the hair that is present on sites which are normally associated with high testosterone, like the beard area or the mustache area. Second is ovulatory dysfunction. So again, clinically and by investigations, you can find out clinically no ovulation at all, no periods. So there is secondary amenorrhea, and pregnancy has been ruled out, other causes have been ruled out. Or based upon investigations, you might have to do repeated ultrasounds to see whether ovulation is occurring or not, or you may have to do repeated progesterone tests or LH to see whether progesterone changes or LH levels change. Is there an LH surge or not? Third is polycystic ovarian morphology, and this is done on ultrasound. But do note that you need a TVS, a transvaginal ultrasound, to actually look for the proper morphology. In practice, in unmarried girls and even in many women, we get the TAS done, trans-abdominal ultrasound done, but it has its limitations and we should be aware of that. So 2 out of 3 are required: hyperandrogenism, ovulatory dysfunction, and ultrasound morphology of polycystic ovary. Hyperandrogenism can be diagnosed clinically or biochemically. Ovulatory dysfunction sometimes clinically, but usually biochemically with progesterone LH or on ultrasound, repeated ultrasound. If you have 2 out of 3 positive, then we will diagnose PCOS. But do be aware of the um, differential diagnosis. The hirsutism may be familial, it may be idiopathic. These are two common ones, especially familial. And many ethnic groups have a different level of hirsutism, which is considered healthy. So, in someone from Manipur, for example, the normal definition of hirsutism will be different from what is seen in Punjab. There is something known as Ferryman Galway score, FERRIMAN Galway, DHLLGALLWEY Galway score. And in practice, we use modified Ferryman Galway score. But I find it difficult as a male endocrinologist to do Ferryman Galway score in all the ladies. Sometimes we give them pictures and tell them to score themselves so they can score every 6 months. But because it is difficult to examine patients in many parts of the country, we follow serum testosterone or we just follow clinical well-being, subjective approach, subjective results that the patient shares with us. Other differentials you should rule out are pituitary, thyroid, adrenal. So, pituitary, patients with Cushing syndrome, Cushing disease may have hirsutism. Thyroid, hypothyroid women have a lot in common with PCOS. The differential has to be made. And adrenal, congenital adrenal, congenital adrenal hyperplasia, CAH. Earlier, we used the term LOCA, LOCAH, late onset congenital adrenal hyperplasia. Now we use the term NCCAH, non-classic congenital adrenal hyperplasia. This is also fairly common. And if you have a lean girl, you think it is PCOS, but you're not very sure it is PCOS, then you will do a 17 OHP, 17 hydroxyprogesterone, to rule out NCCAH. One challenge that we face with PCOS is the differential diagnosis. A second challenge we face is diagnosing it in adolescent girls. So here you have to be very, very careful. First of all, once menarche starts, it may take 2 years for the menstrual cycle to become regular. So the treatment here is counseling, reassurance. Get a TSH done. It is more important to rule out hypothyroidism. Hypothyroidism itself may cause polycystic ovarian morphology. So uncontrolled hypothyroid girls will have large ovaries. In fact, uncontrolled hypothyroid boys have macroorchidia. They have large testicular volume. So you rule out hypothyroid, reassure the daughter and the mother that menstrual regularity may take 2 years to appear, and do a serum testosterone. You might have to do it repeatedly. Do not do a TVS because that is not accepted in India. And just follow up the patient for a year or so. Don't rush to diagnose PCOS. Of course, if serum testosterone is very high, then you should diagnose and you should treat also. But many more often than not, we overlabel. And then the girl, she says, yeah, I have PCOS. So that means I will never lose weight. So I should not exercise. I should not diet. I should not follow healthy lifestyle. So she finds an excuse to blame all her ill health on. And actually, the reason is uh, lack of physical activity, lack of dietary discipline. So one challenge is the differentials, another challenge is in adolescent girls, and third challenge is that if there is PCOS, the risk of metabolic disorders goes up. So all girls and women with diabetes should be screened for PCOS, and all girls with PCOS, all women with PCOS should be screened for diabetes. Do a fasting and a post load. Do an HbA1c if possible, if required. And do not limit yourself to just one test, only a fasting or a post load. Do both. Similarly, apart from metabolic, mental disorders. So, uh, take a history about depression, about anxiety, about distress, even malignancy. So, we said metabolic, makeup, mental, maternity, and menstrual, monetary, and malignant or mitogenic. These are other issues, and you should be able to keep a careful watch on these ladies. Another issue is GDM, gestational diabetes. So, PCOS and gestational diabetes, both are sister diseases, sister syndromes. Both are pre-diabetic, so they are related to diabetes as well. And the good thing is that now metformin has been approved in India and in Europe for use in pregnancy. So if you are giving metformin to a woman who is of reproductive age group, you don't have to stop it before she plans pregnancy. You can continue. So metformin is safe before pregnancy and during pregnancy, all the three trimesters. In general, metformin will not be indicated for hyperandrogenemia alone. It will be indicated in those girls or women with PCOS who are obese, who are overweight, and who are at risk of other aspects of metabolic syndrome. When you give metformin to such a lady, actually androgens also come down, and metformin is able to regularize the periods as well. So it is the most commonly used. However, the first line treatment would be lifestyle intervention as well. If metformin is not tolerated, and our colleagues in gynae sometimes will write 500 milligram 3 times a day, you can use lower doses as well, 500 HS, 250 BD, 500 BD. But if even these are not tolerated, you can always try pioglitazone, or you can try GLP-1 RA like liraglutide and semaglutide. But if you are prescribing pioglitazone, liraglutide, or semaglutide, you have to ensure that contraception is also prescribed to a married woman, to someone who is sexually active, because you cannot plan pregnancy on these drugs. If you wish to use pioglitazone or liraglutide, semaglutide, you can do that. But then after stopping it, the patient should delay pregnancy by at least 2 to 3 months. Some people will come, obese people with or without PCOS, and they will say, I want bariatric surgery. So even after bariatric surgery, someone should wait 12 to 18 months before planning pregnancy. 12 to 18 months after bariatric surgery to allow the body to stabilize. If, however, patient chooses liraglutide or semaglutide and stops it, then after that you have to wait 3 months. Some postmenopausal women with PCOS may benefit from MHT, from menopause hormone therapy. And that would be a topic of discussion on a separate day. But if your patient is symptomatic, do not hesitate to use MHT, estrogen with progesterone. If your patient is not symptomatic and you feel that you want to give medicine for preventing osteoporosis or maybe for improving cardiovascular risk factors, then other better drugs are available. So these are some things that we discussed today about PCOS. But let's just see the questions that we have. Lots of questions coming. And warm welcome to Dr. Monu Gurung from Chandigarh, Dr. Apurva Bishwas from Ramgarh, Dr. Satish Jain from Bangalore, and Dr. Sanjeev Puri from Hoshiarpur. These are the winners of the last week's quiz as well. So congrats, Dr. Monu, Apurva, Dr. Satish, and Dr. Sanjeev Puri. Let's look at the questions as well. And thanks to everybody, Dr. Helen also for joining us in time. And Inam Saab is with us. Hi. Inam Saab is from Pakistan. So warm welcome. It's good to be together. And like we said, we pray for peace and prosperity. We pray for Raman and Shanti. One question from Dr. Nitin Narula is, why is fasting glucose high in elderly? That is because fasting glucose comes from the liver. It is created by a process known as hepatic, that is liver, gluconeogenesis, formation of glucose. But in the elderly, the balance is not all that good, and the liver does not understand how much glucose to release, how much not to release. With every decade, there is an increase in fasting glucose of around 15 milligram percent. So roughly 1 to 1.5 milligram percent per year. So that is one reason. Second is that daytime glucose is associated with daytime lifestyle, and fasting glucose is associated with nighttime lifestyle. So if there is disturbed sleep, that is a cause of stress. If somebody has to get up repeatedly to go to the bathroom, maybe because of a weak bladder or overactive bladder or because of benign prostatic hypertrophy, that is also associated with poor sleep and with reduced with increased stress and with increased release of counter-regulatory hormones and higher glucose. Third, you may find in some patients, they are in the habit of taking a nightcap, little bit of alcohol, or full cream milk, which is the commonest in Haryana. So 100, 200 ml doesn't do anybody harm, but if you're going to take 500 ml at night, then that will certainly cause a high fasting glucose. Muhammad Saab says, Can pioglitazone be given alone in patients with insulin resistance? Yes, it can. And I do use it sometimes. So patients with insulin resistance who are at high risk of hypoglycemia and who actually want to gain weight, then pioglitazone can be used alone. Not many patients, but they are there. And you can also give pioglitazone along with metformin. You can give a fixed dose combination that will have even better result. I hope we've been able to answer all the questions. Related to polycystic ovary syndrome, our take home would be that do think of this in each and every woman of reproductive age group who comes to you. At least do a clinical screening for PCOS. Take a history, take a menstrual history, if nothing else. Ask for any concerns and complaints. Makeup, metabolic, mental, menstrual, maternity related, that is fertility related, also mitogenic or malignancy related, and monetary. Help the patient yourself if you can, otherwise, refer to the right person, to the dermatologist or the endocrinologist. And there are lots of treatments available now. So, that is also something we can counsel the patient about. If there is a girl who is worried about her unwanted hair, maybe we don't want to treat ourselves. Maybe we feel we don't have the expertise, but you can always tell her that yes, expertise is available which will help you, so don't worry. With this, I'd like to thank everybody for having joined us. Thanks to all our colleagues from, okay, a couple of more questions. Sildenafil alternative would be tadalafil. And if HbA1c is 6.4 and fasting glucose is a little bit high, treatment may not be needed. But if fasting is around 125 plus, then there's no harm in trying metformin 500 milligram at night. That would be the simplest medicine. Let's try and see what happens. It will bring down the long-term CV risk. With this, I'd like to thank everybody for having logged in on the first day of the year, and we look forward to meeting you again next week. And I'd like to hand back to Team FDC now.
Thank you, sir. I think today, being the first day of the year, that was a wonderful beginning with our educational journey, 52 weeks essential with Dr. Sanjay Kalra. And we had a wonderful session on PCOS and diabetes today. We look forward to meet and with the next session in the next Sunday. Definitely, sir. We see that again that because of your sessions on 9 p.m. There are regular. Means I received last week regular viewers who were missing because we were running those days the iron talks. They were not aware that we have started with the diabetes essential. So this is the probably first day. Probably we had all our regular viewers of 52-week diabetes essential has come back today. So I welcome them once again with our journey, which continues again. And this is the second year continuously we are running this program to improve the education in the diabetes segment because we had the largest population. Thank you, sir, and Jai Hind, sir.
Jai Hind.